Well, welcome. I'm going to talk today about hepatitis C in women of childbearing potential. Here we go. Okay, well, as usual, you probably did not need me to put this red box to highlight Central Appalachia, but maternal hepatitis C tracks entirely with the opioid epidemic and the overdose death rate. And it's like no matter what slide you put up that's related to this, you'll see the same box around the same geography. And it clearly heavily involves West Virginia, as well as Eastern Kentucky, Southern Ohio, Northeastern Tennessee. And here is data from a 10-year study, a retrospective study that was nationwide, not just Central Appalachia. And it turned out that 0.4% of all births in this country were to women with hepatitis C. But when you think about 0.4%, that's 138,000 women. That's a lot of births. And overall, this rate has clearly doubled over this decade period. And so you can see that on the left, that's the rate. And then on the right, you can see it broken out by racial and ethnic subgroups. And you can see that the rate is highest in indigenous populations and among white women. And as a consequence of this terrible problem, the CDC says we should screen all pregnant women during each pregnancy for Hep C. And then, the liver and ID people say this is a routine part of prenatal care. So everybody's in agreement about that. So here is another retrospective study looking at adverse pregnancy outcomes. And it covers the period 2012 to 2018. And in this study, there were over 52,000 pregnant women with Hep B and almost 134,000 with Hep C. And this was compared to all of the women who did not have any form of hepatitis. And for Hep C specifically, this population was 82% white, 79% Medicaid insured, and 14% delivering in a rural hospital. And if you look at maternal mortality, length of hospital stay, the occurrence of preterm labor, all of these were highly statistically significantly associated with hepatitis C compared to the women who were not infected. So if we think about what is the risk of a woman with chronic Hep C giving Hep C to her baby, it turns out that if the woman only has hepatitis C, so Hep C monoinfection, then it's around 6%. And this is based on 17 separate studies. This was from a meta-analysis by Beneva that's mentioned in the bottom of the slide. And the only caveat about these studies was they were in general studies of relatively small size. But we do know that maternal viral load correlates with the risk. So if the mom has a viral load that's less than 3.5 logs, then it doesn't seem to happen. But if the mom has a viral load more than 6 logs, so that's a viral load greater than 1 million, then the transmission rate to the newborn is 11%. And this was considerably more likely with genotype 1 compared to other genotypes. Now, women who have been infected with hepatitis C and who have spontaneously cleared it, who are in that lucky 15 to 20%, so that their serology labs are antibody positive but RNA negative, have absolutely no risk of transmission because they're not actively infected. If the mom also has HIV, then the co-infection rate then the transmission rate doubles to almost 11%. And risk factors for vertical transmission or mother-to-child transmission, aside from the maternal viral load, include women who have prolonged rupture of membranes, various obstetric procedures that lead to infant exposure, like when they do internal fetal monitoring, or there are lacerations of the vagina or the perineum. And the last risk factor is maternal injection drug use. And of course, that is how these moms got their hepatitis C. But the mode of delivery doesn't play a role here at all, unlike in HIV, where if the mom has a viral load, a measurable viral load, then we recommend cesarean delivery. But this doesn't play a role here for Hep C. And breastfeeding, unlike HIV, also does not transmit hepatitis C unless there is the nipples are cracked and bleeding, and therefore there's Hep C in the blood, and that's a source of exposure to the baby. So those are two important features that we worry about for HIV, but we do not need to worry about for Hep C. So it's not clearly established exactly when the virus gets transmitted. It was generally thought to happen either shortly before or at delivery, but there's been some recent data in a very small number of mother-baby pairs where the virus has been sequenced that suggests that transmission may happen earlier, maybe between 25 and 36 weeks, so in the last trimester. And I think the implication of this is that if we're going to intervene to prevent vertical transmission, we need to do that prior to delivery, and certainly, at the latest, at the very start of the third trimester. So here are the current recommendations from the American Association for the Study of Liver Disease and the Infectious Disease Society of America have, as you know, joint recommendations for everything around hepatitis C. The standard recommendation has been cure the Hep C before these women get pregnant. Now, that's a nice thing to say, but since the majority of women who are getting pregnant have their Hep C through injection drug use and are not typically a population that is eager to seek medical care because of stigma and bad experiences, it's not particularly helpful. During pregnancy, if women do in fact seek prenatal care and are appropriately screened, then clearly what we need to do is appropriate counseling, talk about the potential risk for transmission. Very importantly, talk about the need for follow-up and testing for themselves and their child after delivery. And and tell the pregnant woman that it's possible that the infant will spontaneously clear, and maybe the mom may spontaneously clear the hepatitis C after childbirth. So that's and the other recommendations are that, of course, we should tailor the obstetric care to the individual. We should check viral load and what is misnamed, but what we routinely call liver function tests at the outset of prenatal care to, look for whether they are going to have a viral load that is riskier for transmission, and to see maybe how much damage there is to the liver. Women who develop pruritus or jaundice are a a subset that are really at high risk because the intrahepatic cholestasis of pregnancy is something that happens in women who don't have hepatitis C. And for that to be layered on top of chronic hepatitis C can really be problematic for management. And then, of course, women who have advanced fibrosis, right, cirrhosis, need to be counseled about the danger of maternal, that's inherent in maternal and perinatal outcomes. But because the injection drug epidemic is not that old in West Virginia, it's pretty rare for a woman to have cirrhosis. I've not seen this typically in women of childbearing age. And, you know, breastfeeding is fine unless the nipples are cracked. And, you know, people should be checking these women's viral load after delivery in case they have spontaneously cleared. That would be a wonderful thing. The West Virginia birth score, and on the left-hand side, there's the link for it, has been altered successively over the last number of years to account for different risks that we are aware have been appearing for women who are pregnant. So here, first of all, there used to be look for tobacco use, and now these risks include intrauterine substance exposure. And I have circled because the print is really tiny, the two fields for whether the infant was diagnosed with neonatal abstinence syndrome and whether the mother had maternal hep C. So this is wonderful. This is great. You know, it's a way to be able to identify babies who could be at risk. Part of our problem is that so many of these children wind up in foster care, and the lines of communication can be not optimal in that setting. And, you know, whoever is in charge of taking care of the baby's health may not be aware of what's on the birth score sheet. So one of the things that's happened in the last few years is that some bold investigators have said, why these drugs are very well tolerated, and they come from similar chemical classes as the drugs we use routinely for HIV. And we've been giving pregnant women these drugs who have HIV, we've been giving them these drugs like it was since the early 90s. Why not do that for hep C? And so there's arguments pro and con, and I'll review them with you. So there is, of course, a lot of postpartum loss to follow-up. Again, because this is a population of individuals that is not eager to interact with the healthcare system. You could, of course, possibly have a favorable impact in preventing vertical transmission or mother-to-child transmission, MTCT. Children who do wind up being infected with hep C through vertical transmission can develop cirrhosis at an earlier age than children who acquire them later in life, like later in childhood. And if this is not prevented and these infants are not screened, you know, they can wind up being young adults in their 20s with cirrhosis. And the last argument in favor of treating during pregnancy, when I say during pregnancy, we're really talking about mid-second to early third trimester, starting the therapy in mid-second to early third trimester. Because, of course, first trimester is when organs are being formed, and you really don't want to expose a developing fetus to anything they don't need to deal with in that period. And lastly, surveys have shown that the majority of women who have hepatitis C would be interested in being cured during pregnancy if it would improve the chances that their babies will be Hep C negative. The arguments against treatment is that, we're in the early days. There's not a whole lot of data. There's no preventive measures for vertical transmission. There's also a concern about cost effectiveness. I personally think we should do this. And West Virginia University was supposed to be a site for a study that was going to do this, but the lawyers told me no. So we're not doing that. So the stance on treating during pregnancy has really been shifting, right? So as I mentioned before, right, ideally you'd like to think that we could cure women before pregnancy. But the two professional organizations that issue those joint guidelines have said as of summer of 2020 that we can consider treating during pregnancy on a case-by-case basis after the patient, they said physician, but obviously not everybody taking care of pregnant women is a physician. So I would say after a patient-clinician discussion about the potential risks and benefits. And this is the study that WVU got closed out of. The acronym is STORC. It's a prospective evaluation of Epclusa, sofosbuvir, and vilpatasvir. And the treatment is started in the 26th week of pregnancy. And there are 6 sites across the US and Canada. The closest one to West Virginia is at the University of Pittsburgh. And it started just about a year ago. And they've had trouble recruiting patients, but there have been no transmissions so far, and no serious adverse effects, and the study is ongoing. Probably be a couple of years till we know the outcome. So if you think about the entire period from preconception to postpartum, there's really a number of important harm reduction considerations that could be brought to bear in this setting. One is treating the woman for opioid use disorder. A second is extending postpartum access to care for curative hepatitis C care, and really making an effort to target education and counseling about hepatitis C, and of course for women who are not yet ready for recovery, certainly referral to syringe services. So across the entire spectrum, right, preconception to postpartum, there's just a number of things that we can do. And it certainly includes on our part and the part of the healthcare system, reducing stigma. And for the infant, testing and longitudinal follow-up. And for the mom, of course, preventing reinfection, which is got everything to do with not relapsing to drug use. So just this week, I made these slides a couple of days ago, the CDC came out with new recommendations for the situation of potential vertical transmission. And the background arguments for this were that Hep C elimination is certainly a national as well as a state priority. Also the fact that from 2010 to 2021, acute Hep C rates more than tripled among reproductive aged women. So for women 20 to 29, that went from 0.8 to 2.5 per 100,000. And for women who are 30 to 39, it went from, even worse, it went from 0.6 to 3.5 per 100,000. So really a lot of women whose infants could be at risk. We do now have curative therapy for children who are at least 3 years old. But because many perinatally infected children aren't tested or are linked to care, they miss the opportunity to be treated early before there's damage to their liver. And of course, I already mentioned to you that in 2020, the CDC said every woman should be tested at every pregnancy. So these recommendations take the place of older guidance that used to tell us to test perinatally exposed children with Hep C antibody once they're at least 18 months old. This 18 months is the point where maternal antibody has been cleared. If you test babies younger than 18 months old, you may just be looking at the mother's test result, not the infant's test result. And here are the new recommendations. We are supposed to test all perinatally exposed infants, not with antibody, but with viral load, with Hep C RNA PCR at 2 to 6 months of age. And then consult with a provider who has expertise in pediatric Hep C if there is detectable RNA, because then they will arrange to have annual follow-up with those babies and then be able to treat them when they reach 3 years old. If a perinatally exposed infant does not have a detectable viral load and they're older than 2 months, then they don't really need any specific follow-up unless there's a clinical need for it. And then for older children, those who are 7 to 17 months old, who have not been previously tested, should now get an RNA test. And for those children who are at least 18 months old, who have not been previously tested with Hep C antibody and reflex to viral load, they should also now be tested, because proper identification of these children, referral to care, and critical treatment are not only critical to achieving the goal of hepatitis C elimination, which is what the CDC said, but are clearly critical to ensuring that these children grow up to be healthy. So I'm going to stop the share there, and I am happy to take your questions.
Excellent job again. Thank you so much, Dr. Feinberg, as always. Does anybody have any questions?
I have a question. Thanks, Dr. Feinberg. I always love hearing you present, and I always learn things. So with that stork study and I couldn't understand if those were potential new guidelines or new guideline or established new, or I have forgotten now. Were they potential new guidelines or established new guidelines to do sort of shared decision making, I guess you would call it, with the pregnant person? Would that include people who are still in active use of injection drugs? It seems like we're now treating people who are actively injecting, and now we're saying offer it to people who are pregnant. So it seems you combine the two, you could still offer it to people who are pregnant and injecting. But what's the answer?
So this has not been blessed by the Public Health Service, by the CDC, but the two professional organizations that do those combined guidelines have indeed, as you correctly perceived, have indeed said, you can think about this on a case-by-case basis and talk it over with the mom, the mom-to-be, and see see how that can be worked out. If that's what the woman wants. So I think the bigger issue would be getting access to the drug for somebody who's pregnant. I don't know what West Virginia Medicaid would say about that, to be honest with you. So I don't know that it's been, that's been tested yet. But I think it's exactly what you're saying. If we can treat people who are still injecting and cure them then, why not do that when the women are actually pregnant? But I don't know about access to drug.
Yeah,
That-
okay, that's interesting. Yeah, okay, yeah, okay.
I
Yeah,
think that would be an issue.
one other quick observation, and probably this is math, and it's probably also money. But I was just thinking, it's pretty standard practice to test kids when they're, I think by the age of 2 or between age 1 and 2, Dr. Leonard could say, for lead, exposure to lead. and I've been doing that, and it's important to find, but it doesn't seem very common. So it seems to me that if that percentage of women are have Hep C who deliver babies, and then there's that percentage that babies that it's transmitted to 5.6 or whatever, we should just institute random, or not random, standard screening for all infants for Hep C, as opposed to infants who were exposed as a public health measure.
So I don't disagree with you. I think, the important thing is, if you're doing the lead screening between 1 and 2, you really have to time the Hep C screening to be, beyond 18 months. So when the
Right.
closer to 2, but there are so many women in West Virginia at risk now of sharing their hepatitis C with their newborn, that it makes sense to me as a public health measure. Nobody has officially blessed that at the state level, but I think if we're going to eliminate Hep C, and especially if we're going to ensure that, these are children who are not starting life with all the best possible factors on their behalf, I think ensuring that they do not have chronic hepatitis and do not grow up to have a damaged liver is really important. So I kind of really like that idea. It's just, it certainly, I'm not aware that the family practitioners or any of the other organizations professional organizations in the state have said that we should do this routinely, and nor has the Bureau for Public Health. But I think it makes great sense. And Dr. Rexroad wrote in the chat, and this is truly an issue here. We see a number of infants in foster care without a lot of maternal history. This makes me wonder about testing any 2-month-old whose history is unknown. So this is follows exactly on what you've just asked about, Jen. And that is, I think you could make an argument that, as I just said, that the risk is substantial here in West Virginia. And the earlier you figure this out, the better. But I'm also thinking that I'm assuming that you should be, I've never routinely taken care of children. So I'm assuming that you can get access to the birth score record for that baby, Carmen, that, might be helpful. But you're right. The problem is so many of these infants wind up in foster care and really wind up being sort of disconnected from anybody who can say something clear about, maternal conditions. And that's a very sad thing for those kids. And so, you don't always have it. That's what Dr. Rexroad was saying. Birth score data would be helpful, but we don't always have it. But I guess the issue is there a way to access it? I don't know if that's cataloged online or should be part of the hospital record or the facility record wherever the baby was delivered, right?
Sometimes parents come in with it. I always ask about it even before I knew Hep C was on there, but it's so you would have to call the hospital if the parent didn't have it. It's usually part of the discharge packet, but they don't always have it.
Right. So, I think at least that part's accessible to you. And I think that was the whole point of adding Hep C.
And that's good to know.
To that to that. And I think what the Bureau for Public Health has struggled with because of HIPAA regulations is how to convey to the caregiver of the infant that that there is this risk. And I don't know that that's really been solved, but that would be the ideal situation, right? You would use that birth score sheet and be able to sort of start that conversation with the infant's caregiver. It's complicated. This is one of those situations where I think HIPAA works against the patients. I don't think HIPAA is not always wonderful by any means.
Public health versus personal privacy.
But there we go. So any other questions or anything else I can tell you?
Do you know how they came about this new recommendation? Like, I've not seen any data or research that shows we're testing at 2 months for hepatitis C RNA is better than currently what we're doing.
You know what? These recommendations just came out, and I did not have an opportunity to go myself and look at the references, but it is it is totally available. It's like 30 or 50 pages. It's a substantial document, and it's got lots of references. We did a study at WVU of vertical transmission. We did it in women here in West Virginia, and then women in Metro Cincinnati. There were 2 sites, and because it makes no logical sense to me to be doing something as ancient as antibody and waiting for 18 months to even test antibody. We set that study up so that the infants would have RNA PCR done. Because, if you do 2 RNA PCRs in an adult 6 months apart and they're negative, then that person does not have, oh, good, Rachel Mitchell just put the link in the chat. Thank you, Rachel. Then you can say you can say that person does not have hepatitis C. So it made no sense to us that you couldn't do that for an infant, right? Because if the virus is there and replicating, there should be RNA. And so we set the study up so that that's how we determined whether the baby was infected or not. Study was started like maybe 4 years ago. We're just now submitting it for publication, so well before these new guidelines came out. But it has just always seemed very, often things in the pediatric world lag behind what we do for adults. And sometimes there's just no good reason for it. Sometimes it's just, the idea that you want an extra layer of safety. So you want sort of more data in babies and children than you have in adults. But diagnostic things, this just makes no sense to me for there to have been 2 different systems. So of the 23 women who were evaluable in that study, we did have 1 vertical transmission that was determined by RNA PCR. It was a woman at the Cincinnati site. And we have sequenced the viruses, and it's clear that they're linked, right? It's clear that the infant's virus is from the mom. So, I don't know why we should wait for 1.5 years. I guess some people might say, well, you can't treat them till they're 3 anyway. But I think the sooner you know that an infant's at risk, then you really, you put in motion the follow-up, for them to be in touch with whoever's going to treat their Hep C, have them seen annually so that they're, the connection is made and a relationship is established. And then as soon as they turn 3, give them the curative treatment. And, it turns out that when you treat them that young, their livers are fine. Their livers have no no damage, no fibrosis. And that's obviously the goal. So that's what I can tell you about that, Dr. Leonard.
Awesome. Thank you so very much, everyone. Anybody have a final question before we go into this next portion of our presentation?
Okay, well, thank you very much, everyone, for listening.
Thank you so much, Dr. Feinberg. All right, I'm going to turn things over to Jay so he can help us sign everybody up that's here.